Hi, I'm John Strickler, GI medical oncologist at Duke University, where I am co-leader of the Molecular Tumor Board and also lead the clinical research group here. So I want to start today by talking about the current and future role of molecular residual disease analysis and its relevance in colorectal cancer. When we use the term MRD, there's a couple of different explanations for what that means. Some call it molecular residual disease. Some people call it minimal residual disease. In my mind, there's no difference. It's just how you call it. It's based on this idea that you take a patient who maybe has a tumor in place, remove that tumor surgically, and then create a panel to follow that tumor over time. And the idea is that if you were to detect some biomarker associated with that cancer, DNA or some other epigenomic change, you could potentially intervene during a window of opportunity and potentially alter that patient's outcomes in a favorable way to drive for cure. And I'm a GI medical oncologist, so I see a lot of colorectal cancer. And for me, as a GI medical oncologist, one of the most important questions that I have to face is taking a patient who has resected cancer and determining whether that patient is appropriate for adjuvant chemotherapy. If we look at the example of stage 3 colon cancer, the standard of care is for all patients to get adjuvant chemotherapy, and yet more than half of all patients were cured by surgery alone. So in that case, we're oftentimes overtreating patients. For patients with stage 2 colon cancer, these patients oftentimes have a more favorable risk profile. So the standard of care is frequently no adjuvant chemotherapy, and yet 15 to 20% of these patients will still recur. So in that case, we're undertreating some patients. So the question is, could we use this MRD technology, circulating tumor DNA, to better determine the risk profile of a patient and give adjuvant chemotherapy to the highest risk patients, sparing chemotherapy from patients who are at lower risk? Now, there are two different methodologies currently commercially available to assess this MRD status. And I'm going to go into those here in a little bit of detail. The first approach, which many of us have heard more about to this point, is the so-called tumor-informed MRD approach. This involves taking the tumor out of the patient, sequencing that tumor tissue for a signature of tumor mutations that are specific to that individual patient's tumor, and then creating a personalized PCR assay to look for fragments of DNA that match that original tumor. And the idea is that each patient will have their own individualized signature, and you can follow that over time to potentially detect recurrence before it actually becomes radiologically apparent. The other technology that we're seeing now enter the clinic is the so-called blood-only or tumor-naive test. This one we've heard less about to this point. It does require more advanced bioinformatics to develop this type of assay, but it will typically involve either looking at patterns of methylation on cell-free DNA or looking at specific alterations in the tumor, and then also using this same technique to detect recurrence. Now, this one, because it is technically more challenging, this technology has been under some development over the last several years, but it is entering the clinic as an option as well. This offers some advantages in that it's a little bit quicker. You don't have to sequence tumor tissue. You don't have to access tumor tissue to run this type of a test. So we have limited validation for these tumor-naive MRD tests. This is one of the most extensive validations we've seen to date. This comes from a group in Japan that's done extensive work in this MRD space. Here they looked at the performance of one commercially available blood-only test, where they evaluated the performance of the test in 500 patients with colorectal cancer. And we can see here immediately after surgery, a single blood draw to detect recurrence, we can see that it does successfully distinguish patients between high risk and low risk categories, with patients with a positive result having a 6.5 fold greater risk of recurrence than those patients who have a negative result. This is from a single blood draw after surgery. Then looking at patients who go on to get adjuvant chemotherapy. Once again, this is all colorectal cancer. Single blood draw after completion of adjuvant chemotherapy. We see a further widening of these risk ratios, nearly 12-fold greater risk of recurrence if you're positive after adjuvant chemotherapy. And then when you look at this group of patients over a long stretch of time, multiple blood draws over several years, we see an even greater ability to discriminate high risk versus low risk, with a positive result conferring nearly 17-fold greater risk of recurrence. So we have a bunch of tests now available to us in the clinic, and I would classify them into two broad categories. One is the so-called tumor-informed assays. Some of the commercially available tests are shown here. And then you have these blood-only or tumor-naive tests as well. And we'll be hearing more and more about these tests in the years to come. I will point out that typically the tumor-naive assays include a DNA methylation methodology to them. The tumor-informed tests also have substantial differences in how they're built. Some use a whole exome panel with 16, 48, 50 different variants they'll detect. Some use a whole genome approach, which typically has a much wider variety of alterations they can detect. The theory here is that the more targets you have, the greater sensitivity you have to detect recurrence. But I will say we've not had head-to-head comparisons between these assays to know which is best, because we're not just interested in sensitivity, we're interested in specificity, making sure that when you have a positive result, it actually indicates cancer and it's not a false positive, because ultimately these have major impacts on patient outcomes. So I want to dive in on what we know about the performance of the tumor-informed MRD test in the clinic. This is once again, the group from Japan, which has done extensive work in this MRD space. This is their so-called Galaxy study, where they used the Signatera tumor-informed assay and just looked at its real-world performance. Here they enrolled several thousand patients, so now with over 2,000 patients, stage 2, 3 colon cancer, and stage 4 colorectal cancer. They drew blood before surgery, then immediately after surgery, then 3 months later, and then every 3 months to all the way up to 2 years, and just looked at how the test performed in the clinic. Once again, this was a tumor-informed test. So the first time point they looked at is the so-called MRD window. This window opens up 2 weeks after surgery and closes 10 weeks after surgery, and this is just looking at the performance of the test at this one blood draw. And here we can see that a negative result confers much better prognosis. So we see a 2-year disease-free survival of 85% if that test is negative immediately after surgery, compared to only 20% 2-year disease-free survival for a patient who's positive at that single postoperative time point. We also see a difference in overall survival, though not quite as large. So when you line up a ctDNA test for MRD against classic clinical and pathologic factors, this is a little bit difficult to see, but the one thing that stands out here is you can see the hazard ratio is nearly 12 for risk of recurrence for an MRD positive result, compared to our classic clinical pathologic risk factors, which have a much lower hazard ratio. So this is the most prognostic assay we've got. I did point out MSI. I just found it to be interesting. MSI high disease confers a favorable prognosis in this data set. So these are probably the most important prognostic risk factors we have, being MRD positive versus negative and MSI high versus microsatellite stable. So then the Galaxy study looked at the so-called surveillance window. This opens up after the MRD window closes, or 4 weeks after completion of adjuvant chemotherapy. And we can see here that the prognostic impact of this assay is even greater during the surveillance window. Now, this is during multiple time points. We can see here the hazard ratio for recurrence is nearly 34-fold greater risk of recurrence if you're positive during this window compared to if you're negative. It's really impressive looking at that 2-year disease-free survival. It goes all the way from 93% for a negative down to 9% for a positive. And we also see a gap in overall survival as well. That's, I would call statistically significant and clinically meaningful. So then the next question is, if I get a positive result and I see nothing on a scan, how long will it take me to see something on a scan? And in this data set out of Galaxy Japan using the tumor-informed test, the ctDNA positivity preceded radiologic recurrence by a median of 5.9 months. Then the next question is so important to us in the clinic is, what does this tell us about the use of adjuvant chemotherapy? Now, I will say there's some caveats here. This is an observational data set. This test was not used to prospectively select people for chemotherapy or not, but it took patients with high-risk stage 2 or 3 disease who would typically get chemotherapy, though some people did not. I don't know exactly why some patients were not treated. Maybe they weren't medical candidates. But we can see here for patients with MRD-positive disease, there is an improvement in disease-free survival for those patients that get adjuvant chemotherapy, suggesting that you can treat an MRD-positive patient and alter their outcome for the better. We see a 2-year disease-free survival at 35% for those patients that got adjuvant chemotherapy, and that goes down to almost 3% if they were treated with observation. What's equally as provocative is what we see on the right. High-risk stage 2, 3 disease, but they're MRD negative immediately after surgery. There's no difference in 2-year disease-free survival whether patients got chemotherapy or not. It suggests that perhaps we're overtreating some patients. Now, this is observational, it's not practice changing, but it certainly does support a prospective trial to test this hypothesis further. We can see 89% 2-year disease-free survival for both groups of patients, regardless of whether they got adjuvant chemotherapy or not. So we also have data not just in Japan, but also in the United States presented. This is very similar to the Galaxy study. Here they enrolled nearly 1,800 patients in the United States with stage 2, 3 colon cancer, of whom about a little over 1,100 patients were included in this analysis. Once again, this is a real-world validation of the tumor-informed test from Signatera. Blood was drawn before surgery, immediately after surgery, then 6 weeks after surgery, 12 weeks, then every 3 months out to 2 years. And the bottom line is it essentially replicated the Japanese data from Japan. But what I find, once again, very provocative from this data set is this question of what to do with a positive result, how much adjuvant chemotherapy helps. This data really pretty much validates everything we saw out of the Galaxy study in Japan, in that we do see a substantially better 2-year disease-free survival for adjuvant chemotherapy, but only in those patients who are MRD positive. For those patients that are MRD negative, we see no difference in observation versus adjuvant chemotherapy. Now, this is, once again, not practice changing because this is an observational data set. We don't know why patients were given chemo or not, but it, once again, does support prospective validation of this concept. And then finally, we start to get into this question of, well, why are patients doing better? Presumably, if somebody has a positive result where DNA fragments are detected in blood, we need to do something about it. And the most obvious thing we can do is try to clear out that positive result with adjuvant chemotherapy. How much does that help disease-free survival? The Galaxy study gives us some guidance on this. We see that for those patients that had ctDNA clearance from the MRD window to 6 months after surgery, we see a much better disease-free survival. It goes all the way from basically everyone recurring if you don't clear, up to a 2-year disease-free survival of 60% if you do clear that circulating tumor DNA. But the problem we do face sometimes is sometimes that clearance is transient. What does that tell us? If somebody is initially positive, then clears their DNA, but then it comes back, we see that essentially all of those patients essentially recur. That transient clearance category, it does help the patients, but only for a brief period. Transient clearance is associated with only a 3% 2-year disease-free survival. But if the patient clears and sustains that clearance, we see a really impressive 89% 2-year disease-free survival. Once again, showing how we can use this data kind of to track the progress of these patients in a real-world setting. So when you have a patient in front of you and you maybe they're positive and they clear, and they're nervous about whether they will relapse, whether it'll be a sustained clearance or not, the question that will come up to you as a clinician is, well, when do I know I'm in the clear? And this is, once again, data that comes to us out of Japan, where they looked at this question of transient clearance. And what they found is nearly all patients who had transient clearance recurred within 18 months. So sustained clearance appears to occur usually once a patient gets 18 months out from their clearance, they're usually, their prognosis is excellent. Now, the other question that comes up is this question of spontaneous clearance. Like, did I get a false positive? And in this data set out of Japan, they found 2 cases out of 105 where there was what appeared to be a spontaneous clearance with no action by the clinician. So it is a rare phenomenon. We do know who these patients are. It will tend to be patients who have a very trace positive, like a low positive, and then it will spontaneous clear. We don't know the exact reasons for the spontaneous clearance. It could be an immunologic phenomenon, or it could be maybe a technical error with the test. But the bottom line is it's a very rare phenomenon. So let's start to move into the practical real-world setting of what to do with these results. One of the best studies we have validating this technology in the clinic comes to us from a group of Australian investigators with the so-called dynamic study. Here they took a group of patients with stage 2 colon cancer, and stage 2 is really a perfect setting to test ctDNA because this is a group of patients that we don't have clear guidance on what to do in terms of whether to give these patients adjuvant chemotherapy or not. The data is somewhat ambivalent on whether we're helping patients with adjuvant chemo. So here they took patients with stage 2 colon cancer with R0 resections and then randomized patients 2-to-1 between standard management where adjuvant chemotherapy is at the discretion of the clinician or to a ctDNA guided management where they only got chemotherapy if they were positive. If they were negative, they went to observation. The primary endpoint here was relapse-free survival rate at 2 years. And the first thing to point out is that for that group of patients that were randomized to ctDNA guided management, we can see these patients were half as likely to get chemotherapy. So it went from 28% getting adjuvant chemo in standard management down to 15% in ctDNA guided management. And for those patients who got adjuvant chemotherapy and were in the ctDNA guided category, they were far more likely to get aggressive chemotherapy with an oxaliplatin-based doublet. We also will see that there was a little bit of a delay introduced by using the ctDNA guided management. It was about a 30-day delay to start of adjuvant chemo, so that's something to keep in mind with a tumor-informed assay. Now, here they were using ctDNA guided management using a different tumor-informed assay than the one I had shown earlier that was validated in the Galaxy study in Japan. Looking now at the updated 5-year relapse-free survival and overall survival, we can see that even though patients who got ctDNA guided management were half as likely to get chemo, the 5-year relapse-free survival rate and overall survival rate was identical. So this suggests that you could potentially use a circulating tumor DNA assay to spare many patients adjuvant chemotherapy, and it does not appear to negatively impact long-term relapse-free survival or overall survival. So we also have some other institutional data sets that are very helpful to us. This is the INTERCEPT study led by the team at MD Anderson. Here they took a group of over 1,000 patients and once again validated the Signatera tumor-informed test. And the first question they asked, which I think is very meaningful, if you have a positive result, what are the odds that you see a metastatic lesion somewhere on the same day you draw that blood? And in their data set, it was about a 50-50 proposition. About half of the patients had something radiologically apparent at the time the patient turned positive. The next question is, okay, well, if I have a positive result, how long is it going to take me to find that source of that circulating tumor DNA? And in their series, it was a little over 5 months. So once again, that's giving us a concept of how long it takes to find these. But I think for me as a clinician, having a positive result is pretty nerve-wracking for me as a clinician. It's also nerve-wracking for the patient. And ultimately, we want to get these results if we can intervene and do something about it. We do have some evidence out there that helps us know where to look when you've got a positive result, but your CT scan is negative. I really like the Galaxy data for helping to point the way to where to find that radiologic recurrence. So on our left is the sensitivity of the Signatera tumor-informed test in the so-called MRD window. This is immediately after surgery. And we can see that when there's a positive result immediately after surgery, the red bar represents those patients that are ctDNA positive. We can see that liver metastases are the most common site of recurrence where you've got a positive result after surgery. It's pretty rare, actually, to pick up a lung metastasis by blood immediately after surgery. And then any time after surgery, so these are multiple blood draws, nearly all recurrences in the liver are detected in blood. Still, it's about a 50-50 proposition for lungs. So I think it's important for us to know as clinicians that this is really an exquisitely sensitive tool for detection of liver metastases. It's also pretty good at lymph node metastases, a little less sensitive for local recurrences. But lung metastases, you have to be mindful of. It doesn't always pick those up. So finally, we need to get into the question of what to do with a positive result. And this is one of the toughest questions we face in the clinic. We've shown some data to suggest that adjuvant chemotherapy might be of use for patients that are ctDNA positive. Adjuvant chemotherapy may also not be as valuable for patients that are negative. But what about for patients who've completed their adjuvant chemotherapy and are still positive? This is the ALTAIR study. This was conducted as a spin-off prospective trial out of the Japanese group, out of the Galaxy trial. Here, they took patients who had finished all of their adjuvant chemotherapy and all of their treatments and were still ctDNA positive, and they randomized these patients to 6 months of TAS-102 or a control, a placebo control, and the primary endpoint here was disease-free survival. And although there was a numerical improvement in disease-free survival for those patients that got TAS-102, it was not statistically significant. So unfortunately, trifluridine tipiracil or TAS-102 does not appear to be beneficial for those patients that are positive after completing adjuvant chemotherapy. Another really important study is the so-called Dynamic 3 study. This is, once again, this Australian group that used a different type of tumor-informed test. But here they took patients exclusively with stage 3 colon cancer and randomized them 1-to-1 to either ctDNA informed management or standard management. Patients randomized to standard management, the clinicians were blinded to the ctDNA result. In the ctDNA informed management, the clinicians were asked to nominate a chemotherapy, and if the ctDNA was negative, they were given a de-escalation approach, and if it was positive, they would then have an escalation. So whatever they were planning, they would get something more. For example, if they were planning 6 months of FOLFOX, the patients would get 3 months or more of FOLFOXIRI, or if it was 3 months of FOLFOX, they would get 3 months of FOLFOXIRI or 6 months of FOLFOX. So it was kind of an escalation strategy. And here at ASCO annual meeting, they presented results from the escalation strategy. Could we give something more and change the outcome for a patient? So I will tell you as my editorial here, this is very disappointing results for us. As medical oncologists, we like to think that we're helping our patients with chemotherapy and that more intense chemotherapy is beneficial for patients who have high-risk disease. This data suggests that an escalation strategy does not improve relapse-free survival. On our left, we have the recurrence-free survival curves. Patients actually did numerically better with the standard management approach, with the less aggressive chemo, than with the more aggressive approach with aggressive chemo. And on our right, we can see that ctDNA clearance was not improved by giving an intense triplet chemotherapy regimen of FOLFOXIRI. So this is a bit sobering for us. It suggests that we have not yet figured out what to do with patients who are positive after completion of adjuvant chemotherapy, or for those patients who have high-risk disease based on a positive result. What it does for me as a clinician is it really reinforces the point that we need to understand, where did that disease go? Where is it physically located? Because I think locally directed therapies in the short term are the right answer for many of these patients. But I don't want to end this, Neil, on a down note. There is some promising data on ways to help patients in this setting. So this is the Circulate US study, which is ongoing in the United States. It's led by Dr. Arvind Dasari, Dr. Chris Liu from Colorado, where we are now looking to validate prospectively the de-escalation approach and the escalation approach. This study is ongoing. Cohort A is looking at a de-escalation strategy where patients with, say, stage 3 disease could potentially go onto observation as opposed to adjuvant chemotherapy if they're negative. And then it will also test the escalation approach of doublet chemotherapy versus triplet in patients with high-risk ctDNA positive disease. So I look forward to seeing those results in a couple of years. Additionally, we have some interesting post-hoc analysis out of the CALGB 80702 study, which does give some cause for encouragement that we can do something to improve outcomes for our patients. Now, this was a post-hoc analysis from a large study. It enrolled 2,500 patients, mainly in the United States. All patients had stage 3 colon cancer, and they were randomized in a 2-by-2 fashion to either 6 cycles versus 12 cycles of FOLFOX, and celecoxib versus placebo. Now, the top-line results of this study were presented about 5 years ago. Celecoxib did not improve outcomes in the overall population. This group of investigators went back and analyzed outcomes using the Signatera tumor-informed test and looked at the performance of celecoxib in patients that were positive versus negative, and celecoxib was given for a total of 3 years after completion of adjuvant chemotherapy. So interesting results here. For those patients who were negative immediately after surgery, and it was about 80% of patients, there was no benefit for adjuvant celecoxib. But for those patients who were positive after surgery, there was clearly a disease-free survival benefit for the use of adjuvant celecoxib, hazard ratio at 0.55. So it clearly had a benefit, and that benefit extended overall survival as well, where adjuvant celecoxib was associated with an overall survival benefit, but only for those patients that were ctDNA positive. So I would say that while this is a post-hoc analysis, there are caveats. It was a subset of all the patients enrolled. It is something that we can potentially have at our disposal that has some evidence behind it. And then finally, I want to move beyond the ctDNA MRD story to another thing we can do to help our patients who have resected stage 1 through 3 colon or rectal cancer. This is the Alaska trial, which was conducted in Scandinavia. Here, they enrolled 3,500 patients who had resected stage 1 through 3 colon or rectal cancer and sequenced the tumors for PI3 kinase pathway alterations, and took a group of patients who had PIK3CA mutations in exons 9 and 20 and randomized them between aspirin or placebo for 3 years. It was 2 baby aspirin a day. They also looked at a second group who had more atypical PI3 kinase pathway alterations, randomized them between aspirin and placebo. Once again, 2 baby aspirin a day for 3 years. Primary outcome was time to colorectal recurrence, and we can see a fairly impressive 50% reduction in the risk of recurrence for patients who had a tumor PIK3CA exon 9 or 20 mutation. That was group A. That was the primary outcome. And also that extended to these more atypical PI3 kinase pathway alterations as well, with a 60% reduction in the risk of recurrence with just 2 baby aspirin a day. So this has landed in our guidelines now, and many of us now are sending NGS testing for our patients with resected colon and rectal cancer and looking for these alterations and incorporating this data into our practice. So to wrap up, I think MRD testing is a validated prognostic tool. We have the most data so far on the tumor-informed assays, which have established clinical utility in some select circumstances. Blood-only tests are also coming into the clinic as well and can be useful if we don't have access to tissue or there's a time urgency to get that result. For me, if the patient's MRD positive following definitive treatment, number one, I always repeat the test just to make sure it wasn't one of these spontaneous clearance cases. But the first thing I order if the test is positive is an MRI focused on the liver, because that's where I know I'm most likely to find that maybe subcenter lesion lurking there. And sometimes those can be invisible to CT. I also consider PET. That's sometimes good for picking up a lymphatic recurrence or carcinomatosis. I think there is data to support the use of celecoxib or aspirin in these patients who are positive based on that retrospective analysis. For stage 2 colon cancer, I think MRD could be used as a tiebreaker. If you're undecided about whether to get adjuvant chemotherapy or not, I think we've got enough data to say that this would be a way to break the tie. I'm really excited about some prospective trials that are exploring the clinical utility of an escalation or a de-escalation approach, the so-called Circulate US study. Looking forward to seeing those results. And I finally want to put a plug in to go ahead and send off the NGS test for our patients with especially for patients with stage 2-3 colorectal cancer. And if we find one of these PI3 kinase mutations or PI3 kinase pathway alterations, to go ahead and give 2 baby aspirin a day. It does appear to have a pretty substantial beneficial impact for our patients. So with that, I'll wrap up. Thank you.